Good evening. This is Mrs. Ignacio, and this is a few notes or a few highlights on the neurological system. So this is a few highlights on the neurological system. We're using some pictorial aids today and see maybe that will help students a little bit better. So when we talk about the neurological system, I just want to review a few things as far as the neurological assessment goes. So when you're performing your neurological assessment, make sure that you have a history of the present illness. You're going to look at the patient's mental status. You're going to look at their level of consciousness. Are they alert, lethargic, obtunded, stuporous, or comatose? You're also going to see if the patient is oriented and what their affect is, their facial expression, what is their mood, how is their speech, is it clear, consistent, are they able to easily find words. You're also going to look at their cognition, making sure that you're also assessing the cranial nerves. Remember your cranial nerves 1 through 12, and one of the pictorials will talk later on in this will show you the cranial nerves and a mnemonic to help you remember the cranial nerves. We're also going to be looking at their motor function, the size of their muscles, the symmetry, the tone, and strength. We're also going to be looking at coordination and movement. What about the voluntary movements, the involuntary movements, any tremors, any twitches? Do they have issues with their balance or gait? We're also going to be looking for any posturing. And so this picture shows abnormal posturing. And so we have decorticate posturing. And decorticate posturing is also known as flexion, and this is an abnormal posturing indicated by rigidity, flexions of the arms to the chest, clenched fists, and extended legs. This is indicative of damage to the corticospinal tract, the pathway between the brain and the spinal cord. The second posturing you have is decerebrate posturing or extension posturing, and this is an abnormal body posturing indicated by rigid extension of the arms and legs, and it's downward pointing of the toes, ballerina toes, and backward arching of the head. This is indicative of deterioration of the structures of the nervous system, particularly the upper brain stem. Okay, and so the other picture shows someone that is flaccid, so their muscles are limp. Okay, going to the next slide or the next pictorial that we have ALS. ALS. And so there's a lot going on in this picture, but let's talk about ALS. So ALS is a progressive, invariably fatal neurologic disease that attacks the nerve cells, the neurons, that control voluntary muscles, also known as Lou Gehrig's disease. So these are the manifestations of ALS. There's going to be twicking or fasciculations, cramping, and muscle weakness, fatigue, slurred or nasal speech with difficulty forming words, and that is also known as dysarthria, difficulty chewing and swallowing, dysphagia, overactive deep tendon reflex, fatigue, and some patients may experience cognitive impairment. Eventually, respiratory compromise will take place, and death usually occurs from respiratory failure, infection, or aspiration. The etiology is unknown, and there's no cure. Treatment is just treating the symptoms. So for collaborative care for ALS, we're going to provide education, we're going to provide information and support. We're also going to look at the home support system. We will implement aspiration precautions and alternate methods of communication as they are needed. We will support the respiratory function, maybe through mechanical ventilation or non-invasive positive pressure ventilation. We will administer medications to provide relief from excessive salivation, pain, muscle cramps, constipation, and depression. We will provide supportive services to the patient and their family, and also provide support as they may have anticipatory grieving. The medications that we can expect to administer in the patient with ALS is a glutamate and antagonist. And so riluzole may have a neuroprotective effect in the early stages. To manage the spasticity, we may give baclofen, dantrolene sodium, or diazepam. So for client education and referral, we will look at the disease progression and the prognosis, make sure the patient has an advanced directive in place, interventions to maximize respiratory function and prevent infection. We will also look at strategies to prevent aspiration. Alternate communication methods may be used, and we will refer this patient to occupational, physical, and speech therapy, home care, and hospice care when needed. Okay, so the next picture shows us autonomic hyperreflexia. So autonomic hyperreflexia occurs when there is some kind of injury to the spinal cord in the upper back. So this picture shows us it's T6 or below, and that is your thoracic vertebrae, number 6. And so the issue is that autonomic hyperreflexia will make your blood pressure dangerously high, coupled with very low heartbeats, and it can lead to stroke, seizure, or cardiac arrest. We are also considered about the patient's breathing. And so this picture is showing things that can offset the condition. So constipation, kidney stones, urinary tract infection, inserting a catheter or any kind of tube, hemorrhoids, irritated or blistered skin, and pressure on the scrotum in men, and sexual stimulation can create an issue for your patient that has this particular condition. So some of the symptoms may be heavy sweating or diaphoresis, anxiety, a slowed heart rate, blurry vision, goosebumps on the lower body, difficulty breathing, and maybe a stuffy nose. So for this patient, we want to make sure that they have a regular toileting schedule, look for signs and symptoms of a bladder infection, make sure we're inspecting their skin, no tight clothing, no restrictive clothing, and it may be an emergency if they get into a crisis kind of situation. So we really have to pay close attention to this patient. All right, so this is the autonomic nervous system response, and this speaks to the fight or flight, or rest and digest. So the autonomic nervous system is consistent of two antagonistic sets of nerves, the sympathetic and parasympathetic nervous systems. The sympathetic nervous system connects the internal organs to the brain by spinal nerves. When stimulated, these nerves prepare the organism for stress by increasing the heart rate, increasing blood flow to the muscles, and decreasing blood flow to the skin. The nerve fibers of the parasympathetic nervous system are the cranial nerves, and primarily the vagus nerve and the lumbar spinal nerves. When stimulated, these nerves increase digestive secretions and reduce the heartbeat. Okay, again, so the sympathetic is fight or flight. That is your stress response. And parasympathetic response is rest and digest, and this is showing you peace. Okay, let's look at the next slide. And so this slide is speaking to Bell's palsy. And so Bell's palsy is also known as acute peripheral facial palsy of unknown cause, and it can occur at any age. For most patients, the Bell's palsy is temporary. The symptoms usually start to improve within a few weeks, with complete recovery in about 6 months. A small number of people continue to have some Bell's palsy symptoms for life. Rarely, Bell's palsy can reoccur. And so the symptoms that your patient may experience is a rapid onset of mild weakness to total paralysis on one side of the face, occurring within hours to days, a facial droop with difficulty making expressions such as closing your eye or smiling, drooling, pain around the jaw or in behind the ear on the affected side, increased sensitivity to sound on the affected side, headache, a change in the amount of tears or saliva they produce, or a headache. So the patient should seek immediate help for this, because they want to make sure that this is not a stroke, because the symptoms are similar to a stroke. Okay. All right, so this speaks to left-sided CVA. So when we talk about CVA, it's a cerebral vascular accident. So CVA is commonly referred to as a stroke or a brain attack, and it's the sudden loss of brain function resulting from a disruption of blood supply to the involved part of the brain. So when we have a left CVA, that means we're going to have a patient that's going to have physical symptoms on the right side of their body. Okay, and so contributing factors to CVA is hypertension and obesity, smoking or cocaine use, hyperlipidemia, diabetes mellitus, peripheral vascular disease, aneurysm, or cranial hemorrhage. So the manifestations for CVA consist of a neurological deficit, and it's determined by the location and the extent of the tissue ischemia. Remember that ischemia is lack of blood flow, so that means lack of oxygen and lack of O2. So the patient may experience a change in mental status, slurred speech, aphasia, dysphagia, numbness or weakness of the face or extremities, especially on one side of the body. They may have a visual disturbance, cranial nerve disturbance, loss of balance or coordination, a sudden severe headache. So this particular picture is showing a left-sided left CVA, and so the affected part of the body is going to be the right side. And so it's showing you impaired speech, language, slow performance, visual field deficits. And so left brain damage is right body weakness. I'm going to go to the next slide so you'll be able to look at the effects of a right-sided CVA as I discuss the nursing interventions for your CVA patient. You want to maintain their airway, monitor neurological function and vital signs, establish baseline level of function on the Glasgow Coma Scale, maintain fluid and electrolyte balance, monitor for aspiration due to risk of dysphagia, difficulty swallowing, feed the patient slowly, placing the food in the back of the mouth and then to the unaffected side. Provide psychological support to the client and family. Establish a means of communication with a client who is experiencing aphasia, that is expressive aphasia, receptive or global aphasia. Encourage slow, deliberate speech. Make sure we're performing our range of motion exercises to prevent flexion contractures. We want to keep the extremities in a position of extension or in a neutral position. Maintain the skin integrity. And we have a couple slides coming up that will talk to the different kinds of paralysis that the patient may occur in the CVA patient. Help the client to achieve bowel and bladder control, and think about hemaniopsia. And so hemaniopsia is when the patient is having one-sided visual neglect. So we have to make sure that we place items within the patient's visual field, especially if it's a mealtime. You want to make sure that you place things in their visual field. So for therapeutic measures, we can expect thrombolytic therapy, and that is for your ischemic CVA, and it is contraindicated if it's been more than 4 to 5 hours since the patient experienced the ischemic CVA. And remember, ischemia is when there is a lack of blood flow, lack of oxygen and nutrients to a part of the brain. Surgical management may take place for a hemorrhagic CVA if there is a hemorrhage. Blood clots will be surgically removed. Endovascular interventions, and so we may have an embolectomy and a carotid artery angioplasty complete. They may place a stent in this particular CVA. So for client education and referral, we'll refer them to occupational and physical therapy as well as speech therapy. Okay, now we're going to look at cholinergic crisis. So a cholinergic crisis may occur in your patients with myasthenia gravis. And myasthenia gravis we're going to speak to a little bit later, but it is a neuromuscular disease. And so when cholinergic crisis occurs, there may be a couple reasons why the patient has a cholinergic crisis. So it's two main reasons. It's a nicotinic crisis in which the muscle weakens and twitches involuntarily. The patient may experience dysphagia or the difficulty in swallowing, and they may have cramping. Or so there could be a muscarinic crisis. So that's the second type. The first type is nicotinic crisis, and then the muscarinic crisis. And inside in the muscarinic crisis, vision becomes blurry, pain in the abdomen, vomiting, diarrhea, nausea, discharge, and a secretion of tears with too much secretions within the bronchial passages. So this picture shows you, okay, what are the symptoms, the signs and symptoms of a cholinergic crisis. So SLUD is the acronym. So salivation, lacrimation, shedding of tears, urination, and defecation. So that's what this is referring to, your cholinergic crisis, and there's two different types. Let's now look at the cranial nerves. So the cranial nerve mnemonic that's there is there to help you remember your cranial nerves. So cranial nerve number 1 is olfactory, sensory, smell. Cranial nerve number 2 is optic, it is sensory and vision. Cranial nerve number 3, ocular motor, and it's a motor nerve and it controls the eyes. Cranial nerve number 4 is trochlear. It's a motor nerve and it controls the eyes. Cranial nerve number 5 is trigeminal. It is sensory for the face, motor, and also controls chewing. Cranial nerve number 6 is the abducens nerve. It's also a motor and it controls the eye. Cranial nerve number 7, the facial nerve. It's sensory and it controls or innervates the face and hands. Cranial nerve number 8 is the acoustic or auditory, and it's sensory and it's for hearing and balance. Cranial nerve number 9, glossopharyngeal. It's sensory and it's posterior taste. Cranial nerve number 10 is the vagus nerve. We think of Valsalva, bearing down, sensory, throat, motor, swallow, speech, cardiac innervation. It slows down the heart rate. So cranial nerve number 10, if your patient is valsalving, if they are trying to pass a bowel movement, their heart rate will drop. And that is very dangerous for your patients if they're unattended, sitting on the commode, and they already suffer from bradycardia. Okay. Cranial nerve number 11, the accessory nerve. It deals with its motor, the throat, neck muscles, and the upper back. Cranial nerve number 12 is hypoglossal, and that's motor and tongue. All right, so here we have a picture that's showing us what do we do to help our patients with a CVA. We want to help them, assist them on the functioning side. So if you ever have a question that says, how do you assist your patient that has a CVA survivor, you will be on their you will be on their functioning side, okay? You will help them on their functioning side, okay? The side that is unaffected, okay? All right, so this is Duchenne's muscular dystrophy. So Duchenne's muscular dystrophy is it's a type of disease that makes the muscles weak over time. And so it is genetic. And so children that have this condition have a difficult time standing up. They usually need wheelchairs. They also have a lot of cardiac and respiratory issues. Usually there's not a long life expectancy for these particular patients. Okay, so it is X-linked inheritance, so it's primarily in males. Okay, all right. Excuse me, the next slide is speaking to FAST as far as recognizing a stroke. So FAST, the F stands for face. You have them smile or puff their cheeks out. Arms is the A. Can they raise both arms? And then the S is speech. Is their speech slurred? Can they make a sentence? Are they making sense? Is it coherent and logical? And then T is the time. You have to get help immediately because the medications that must be administered have a specific time frame that they're limited to. So you have to get help immediately. All right, let's now look at Guillain-Barré's syndrome. All right, Guillain-Barré syndrome. So this is an acute autoimmune attack on the peripheral nerve and some cranial nerve myelin, okay? So the manifestations of this, it's usually preceded by an infection, a respiratory or gastrointestinal infection. And so it usually presents with ascending weakness, which may progress to paralysis, leading to acute respiratory failure. There is hyperreflexia, so too little reflex. Recovery takes several months to years. So there is hope because there is actually recovery, but there is also paresthesia and pain. So your nursing interventions for a patient with GBS, also known as Guillain-Barré syndrome, GBS, assess the respiratory status and provide respiratory support as needed. That's why in the picture there's oxygen and the ventilator. Monitor the vital signs in an ECG. Provide nutrition and prevent aspiration. They may need parenteral supplementation. Manage bowel and bladder problems, collaborate with physical therapy to maintain the client's muscle strength, flexibility, and contractures. Prevent complications of immobility, pneumonia, deep vein thrombosis, urinary tract infection, atelectasis, and skin breakdown. Decrease anxiety by providing information and support. Therapeutic measures for this patient: respiratory support, and they may need mechanical ventilation. They may need a plasmapheresis. Intravenous immunoglobulin may be administered. So for client education and referral, we want to refer to occupational, physical, speech, and respiratory therapy. Teach strategies to prevent complications of immobility, and inform the patient that recovery may take up to 2 years. So that's really important to educate your patient. All right, so this slide is very busy. There's a lot going on, and there's always a lot if the patient has IICP. So I'm going to talk to you a little bit about IICP, which is increased intracranial pressure. So this is a rise in pressure within the skull that can result from a trauma, some kind of brain injury. So these are the contributing factors: a head injury with subdural or epidural hematoma, so a bruise, a blood bruise in the brain; cerebrovascular accident or cerebral edema; brain tumor; hydrocephalus; a ruptured aneurysm and subarachnoid hemorrhage; meningitis or encephalitis. So the manifestations may depend on the actual cause of this increased intracranial pressure. It also will affect the level of consciousness. So the earliest sign of IICP can be changes in the level of consciousness, such as restlessness, confusion, drowsiness, lethargy, or stupor. Motor and sensory changes may also take place in your patient. The patient may complain of headache, diplopia, which is double vision. They may have experienced irritability, nausea, vomiting, and this vomiting is often projectile vomiting. Let's see, pupil changes. The pupils will be dilated, unequal, maybe non-reactive to light. Changes in the vital sign we will see, and I'm going to go to the next slide, speaks to the Cushing's triad. And so Cushing's triad is the opposite of shock. So in your patient that has shock, that probably means that they have too little fluid, right? Fluid volume deficit. Their blood pressure is dropping, their pulse is increasing, and so is their respiration. But for your patient that has IICP, increased intracranial pressure, their systolic blood pressure is increasing, their pulse is decreasing, and their respirations are decreasing. So in the Cushing's triad, we have hypertension with widening pulse pressure, bradycardia, and irregular breathing, also known as Cheyne-Stokes respirations. And they also have ineffective thermoregulation. So for your patient with the IICP, we want to monitor the vital signs, the neurological function, keep the head of the bed elevated 30 to 45 degrees, keep the client's head in a neutral position to enhance any drainage of fluids, avoid coughing, sneezing, straining, and suctioning, anything that would increase the pressure in their heads. Okay, you want to avoid that. Maintain maximum respiratory exchange. Okay, so hypercapnia causes vasodilation, thus increasing the intracranial pressure. Administer oxygen to increase the supply to the brain. Monitor their I's and O's. Restrict fluids to prevent increased cerebral edema. Administer medications as prescribed. And you're going to use hypothermia as prescribed to decrease the ICP. Decrease the environmental stimuli. Intensive care is required when monitoring the ICP. Okay, so intensive care may be required when you're monitoring the ICP. Medications. Avoid opiates and sedatives unless ventilated. Okay, will restrict neurological assessment. Okay, so barbiturates to place a client in a therapeutic coma with the ventilator support and close monitoring of cardiac status. Acetaminophen may be used for fever, and osmotic diuretics such as mannitol and steroids may be used to decrease cerebral edema. Okay, this is another picture that speaks to the IICP. Okay. All right, so this next picture shows the levels of the spinal nerves. And so that's important to consider if you have a spinal cord injury in your patient. We have our 8 cervical vertebrae, then 12 thoracic, 5 lumbar, and 5 sacral. So if the patient has damage at one of the levels, anything below it will be affected. And so we have spinal cord injury is a partial or complete disruption of nerve tracts and neurons, and thereby resulting in paralysis, sensory loss, altered activity, and autonomic nervous system dysfunction. Contributing factors for spinal cord injury is a male 16 to 30 years old, motor vehicle crashes, falls, violence, sporting activities. So there's different types of spinal cord injuries. So there's a contusion, laceration, compression of the cord, a complete transection, which means the patient is paralyzed below the level of the injury. Manifestations of spinal cord injury are determined by the level of injury. So cervical can be partial or complete quadriplegia or tetraplegia. Respiratory dysfunction, so the patient may be ventilator dependent. Partial or complete paralysis of all 4 extremities, and then loss of bladder and bowel control, alteration in sexual function. So those were all manifestations if there was a cervical spinal cord injury. So if it's at the level of the thoracic vertebrae, the injury, the patient will present with a partial or complete paraplegia, loss of bladder and bowel, alteration in sexual function, partial or complete paralysis of lower extremities and major control of body trunk, potential complication of autonomic dysreflexia, injury above the T6, and then respiratory complications. If the injury takes place at the lumbar vertebrae, partial or complete paralysis of the lower extremities will take place. Loss of bladder and bowel control and alteration in sexual function will occur in this patient as well. So our nursing interventions for this particular patient, we want to immobilize the patient, put them on a spinal board. They may have halo traction, Garner-Wells traction, or Crutchfield tongs, or they may have a cervical collar. Maintain and monitor respiratory function. Monitor for spinal shock, loss of sensation, flaccid paralysis, and reflexes below the level of the injury. We will monitor them for neurogenic shock, and neurogenic shock is when the patient has decreased blood pressure, heart rate, and cardiac output, as well as venous pooling, okay? Venous pooling, we want to be careful about that. We will monitor for autonomic dysreflexia. And so we talked about autonomic dysreflexia in the previous slide, but remember that certain stimuli can actually trigger life-threatening hypertension, okay? And so this noxious stimuli can create a life-threatening situation for the patient. And so those noxious stimuli may be from impaction, bladder distension, pressure points, ulcers, or pain. So we really want to carefully monitor this patient for those complications. All right, so let's see. Excuse me. So other nursing interventions that we want to perform for a patient with a spinal cord injury is to place the patient in a high Fowler's position to help decrease the blood pressure, determine and remove causative stimuli, teach the patient how to manage their bowels and bladder. They may be on a bladder and bowel training program where you toilet them every couple hours. And you will administer the medications as prescribed. The therapeutic measures for this patient with spinal cord injury may be surgical management, and they will also have to see occupational therapy as well as physical therapy. All right, so this picture speaks to migraine headaches, and it talks about the symptoms that goes along with it. Sometimes your patients may have an aura that's like maybe a light halo. They may have a certain smell that tells them that the migraine is coming on. And so the migraine could be pulsating. It could last for 4 out to 72 hours, so it can last 4 days. It could be really crippling, debilitating, and so they can't function. They're also really sensitive to light, to sound. So you want to make sure that this patient has low stimuli and that they're in a safe place. All right, multiple sclerosis is going to be next. And so this is a chronic progressive immune-mediated disease of the central nervous system. It's characterized by patches of demyelination in the brain and spinal cord, and the symptoms occur during relapse and remission. So it's a relapse and then remission, relapse and remission. And so the exact cause is unknown. So the contributing factors for MS, multiple sclerosis, is age. It's young adults to 20 to 40 years old, and it takes place mainly in women. Geographic, so it's looking at those that have European, they're from New Zealand, Southern Australia, Northern US, or Southern Canada as their background. Genetic predisposition is one of the risk factors as well for multiple sclerosis. So the manifestations vary in relation to the location of the lesion. Okay, and so these lesions again are within the central nervous system, so within the brain and the spinal cord. So the MRI shows sclerotic patches through the brain and spinal cord. The patient will also manifest with fatigue, visual disturbances, nystagmus, blurred vision, diplopia, slurred speech, spasticity, and weakness of the extremities, paresthesia, numbness, and pain. Emotional lability, that means that they go from happy to sad, happy to sad. Depression, intention, tremors, and so that's when they're actually going to reach for something, they will start to tremor. They may have a spastic bladder as well. How we manage this, there is no cure, so we have to really alleviate the symptoms and try to decrease any relapses that the patient may have. During the exacerbation, we will administer corticosteroids as they are prescribed by the physician. Stress management techniques may be helpful to prevent any exacerbations. Also avoiding the patient becoming very dehydrated or overheating. So that's important for these patients. So your nursing interventions, you want to promote independence and maintain an active, normal lifestyle as much as possible. You want to teach the patient how to self-catheterize if it's necessary. Promote daily exercise with fall precautions. They are very at great risk for falling since they have that muscle weakness and that spasticity. Teach the self-injection technique in case they need to administer any medications. And you also want to monitor for safety and injury prevention. The medications given to your patient with multiple sclerosis consist of immunosuppressants, and they also will be given medications for muscle spasticity and tremors like baclofen, gabapentin, and clonazepam. We also want to look for urinary problems and problems with constipation. So we will also look for issues with depression. And so amitriptyline, sertraline, or fluoxetine may be given. Sexual difficulties may occur, and so they will be given sildenafil. For fatigue, they may get modafinil and amlodipine. Okay, so the client education and referrals. We will refer this client to occupational, physical, and speech therapy. Medication administration will be taught, including self-administration. We want to teach them how to prevent a relapse and self-catheterization if necessary. All right, so this slide speaks to the different types of paralysis. So quadriplegia is now also known as tetraplegia. So that means your 4 extremities are paralyzed. Hemiplegia, that means half of the body, which usually occurs with a CVA. Okay, so that is half of the body, meaning left side versus right side. And then paraplegia means that the lower extremities are affected or paralyzed. All right, let's now talk about Parkinson's disease. So this is a chronic progressive neurological disorder caused by the loss of pigmented cells of the substantia nigra and the depletion of dopamine. The manifestations of your patient with Parkinson's, they have bradykinesia with rigidity. So they have reduced movement and they are very rigid. Their muscles are rigid. They have a resting tremor. So instead of the intention tremor, like with multiple sclerosis, when they reach for something, they start to tremor. This patient is at rest, not reaching for anything, and they will tremor. Postural, gait, and disturbances. Okay, postural and gait disturbances. So their posture is stooped and their walking is a shuffling gait. Their expression is fixed. So they don't have any expression. They kind of look like they had a lot of Botox. And they can't smile, okay? It's a mask-like faces is what they're really referred to, or flat affect. Depression, drooling, slurred speech, or other manifestations. So your nursing interventions for this patient with Parkinson's disease. You will teach fall precautions, encourage clothing that fosters independence, no snaps, buttons, or zippers. Also encourage a high-fiber diet. The medications that will be given for this patient, anti-Parkinsonian agents, levodopa, dopamine agonists will be given, anticholinergics, antivirals, as well as antihistamines. So the therapeutic measures, so this patient may have a neural transplantation, a deep brain stimulator may be installed. They also may have a thalamotomy or a pallidotomy. And so the patient may also be educated on injury prevention, medication regimen, adequate nutrition, strategies to improve bowel and bladder function, the use of assistive devices, and we will refer them to occupational therapy as well as physical therapy and speech therapy. All right, posturing again. So this is just another pictorial of helping you remember. Decorticate, bringing to the core, and decerebrate is extending. The arms are like E's. So this is a pretty cool one. All right, seizures. So seizures, I know that we have talked about seizures a lot. Let's take a look at this picture. This is talking about the different kinds of seizures and what you will do for your patient with seizures. So seizure disorders are abnormal, sudden, uncontrolled, excessive discharge of electrical activity within the brain. So there's contributing factors. It could be drugs or alcohol withdrawal, maybe due to trauma, maybe due to brain tumors, toxicity or infection, or a fever. So there's different classifications of seizures. Generalized seizures, so a tonic-clonic seizure where they have both phases, the tonic that's the first picture you see, and then clonic, the patient is contracting. They're also known formally as grand mal seizures. We have absence seizures where it looks like the patient is just staring straight ahead, and if you wave your hand in front, they won't blink their eyes. They're not with you there physically. And then there's myoclonic seizures, atonic, and akinetic seizures. So with the atonic or akinetic seizures, that's when the patient actually falls down, possibly. They're also known as drop attacks. There's also partial seizures, which are complex, usually with impairment of consciousness. There's simple seizures, usually without alteration in consciousness. Okay, so for your nursing interventions, you want to maintain a patent airway, position them on their side, monitor respiratory status, and loosen any restrictive clothing. Make sure that the patient is safe and free from injury. Do not restrain the client. Do not put anything in the client's mouth. Turn the client's head to the side to prevent aspiration. Document observations before, during, and after the seizure. So you wanted to also ask the patient, do they have an aura? Do they feel it coming on? Do they have a sense? It might be a light or a feeling, a smell, or a taste in their mouth that tells them it's a warning that the seizure is coming on. Also document how long the patient remains unconscious. Determine if there's any incontinence of bladder or bowel. Identify any precipitating factors. And you want to monitor and document the behavior during the post-ictal phase. And the post-ictal phase is the period following the seizure. So the patient may be very tired and be very confused after they have the seizure. So you have to reorient them and allow them to rest in a low stimuli environment. All right, let's see. And make sure that there's oxygen available and suction is available. Bed rest should include padded side rails and fall mats on the floor. Medications that may be given to your patient that has a seizure disorder consist of phenytoin, carbamazepine, valproic acid, phenobarbital, levetiracetam, and topiramate. So we want to educate the client by letting them know it's important to take their medications and do not stop abruptly. They have to take this medication consistently and on time, so there's maintaining of therapeutic levels of the medication in their system. They also need to understand the signs and symptoms of medication toxicity. They have to get proper rest to minimize fatigue, avoid alcohol. They should also wear a medic alert bracelet. That is very important. So if something happens to them while they're in the public, people will know that, okay, this patient or this individual has a seizure disorder. They need to keep up with all of their appointments and identify any triggers that they know, and please avoid those triggers. Status epilepticus is a life-threatening condition characterized by a series of generalized seizures without full recovery of consciousness between the seizures. And so it may be caused by a sudden withdrawal of anticonvulsant medications and can lead to brain damage or death. So for this patient that is in a status epilepticus condition, we will initiate seizure precautions. We will administer lorazepam or diazepam or phenytoin. Okay, so we will monitor also for bradycardia and for heart block. Okay, and so we will do those things to keep our patients safe that are in status epilepticus. All right, so spinal cord injury, we talked to a little bit before in previous slides, but the higher the level of the injury, the more severe that the side effects the patient will face. So if there's an injury at the level of the cervical vertebrae, everything below that particular vertebrae is going to be affected. So the higher the injury, the greater the loss of function in your patient. Okay, again, this is another one that talks about spinal cord injury and the areas of paralysis. All right, this slide speaks to stroke. We mentioned stroke before, and it has some modifiable factors, things that are non-modifiable, and modifiable being things that the patient can control. Non-modifiable, they cannot control. For example, they cannot control their age or their gender or their family history. And so this talks to your nursing goals, airway, decrease their intracranial pressure, nutrition, safety, education. So all of those things are important. All right, this is another picture so you can understand what's going on. The stroke, also known as the brain attack or the CVA, and it gives you details and a really good visual of what your patient will look like who has suffered a stroke or who is suffering a stroke. Okay. So stroke recognition, so there's 3 steps, and that also will be like what we saw in that slide that shows FAST. So this is very similar, okay, to FAST. Okay, next we have tetanus, and so also known as lockjaw, okay? And so this patient will have facial spasms, jaw stiffness, fever, restlessness, sweating, also known as diaphoresis. So progressive involvement is going to, with their body is going to occur. And so there is a prevention of tetanus, right? That tetanus shot that we have to get every 10 years. And so if a patient has maybe stepped on a rusty nail and it's been 9 years since their last tetanus shot, the doctor may say, okay, it's time to give you another shot, okay? So we really want to make sure that we stay up on our tetanus vaccine. All right, so this last slide speaks to the warning signs after a head injury. And so this is your pediatric patient, but again, it's for any patient. After a head injury, we have to really carefully monitor our patients. And so it could be a child falling out of the bed, or it could be someone that has fallen off of a ski lift. It could be a trauma, a motor vehicle accident, but we really want to carefully monitor all patients that have had any kind of head trauma. It could also be sporting, something as simple as little Johnny and little Susie bumping into each other when they're running on the playground. So we want to look for any changes in levels of consciousness, seizures, any bleeding or drainage from the nose or the ears. If you have clear fluid coming from the ears, that is an abnormal finding, especially coupled with a head trauma injury. That is definitely a cause for concern. Okay, and so projectile vomiting, slurred speech, visual disturbances. So these are all warning signs after a head injury. So this says 24 hours. Usually the doctors will tell you to monitor a child for at least 48 hours to make sure that they're easily rousable. Okay, this will conclude our discussion of neurovascular or the neurological system. Thank you. And I want to remind you to always think like a nurse.